I'll give it a few more minutes. Only 8 of us are here. I think we said before we left out of class last week, we would discuss a couple documents. One we'd be discussing again. The other one I think is a new one that I placed in the announcements. Then for our in-class assignment, and I'll put you guys in breakout rooms and you'll work together on a task. Of course, all of you are doing your individual task, but we're going to go to our simulator. You're going to go to the book, that PDF that I provided you for the chest, but you're going to go to the upper extremity chapter. And I think it's slide, I don't remember the slide number, but I did put it in the ICA. And you're gonna look, we're gonna do the hand, and it's going to be the PA, oblique, and lateral hand. You're gonna produce those images in your little teams, of course, each individually. That is what you will be uploading for your in-class assignment, and we'll discuss it as soon as you guys get back to the main forum. So, let's see, not that. Let me see what I said. All right, we said we will look at the functional capabilities. And what else did I say? Oh, the electives again. It's not working. All right, so I'm going to share my slides. So far, I only have 11 students. And 12. So I have Amanda, Ashley, Corey, Daniel, Dominique, Elizabeth, Jasmine, Kennedy, Madison, Mercedes, and Mindy. So I'll give them a few more minutes, but we'll go ahead and get started on those tasks that I owed from last week. All right, so hopefully you can now see an example of the functional capabilities that we as technologists need to have, or if we're getting down to the bottom part when we're talking about critical thinking and interpersonal skills and communication, that is something that we can improve and get while we are in school. For you all, it's going to be a little bit more important for you, especially your interpersonal skills, your communication. Is going to be important for you to try to engage in activities where you can, I guess, improve those before you hit your clinical setting. All right, but the functions that we need to have as a technologist are in the categories of vision, hearing, gross motor, fine motor, critical thinking, interpersonal skills, communication, emotional, and also environmental. All right, so the requirement as far as vision for us as technologists, we need to be able to discriminate between black, white, and scales of gray. Anybody want to give a reason why it's black, white, and scales of gray? Is my volume not on? Hold on. Yeah, my volume's on. Can y'all hear me? No one wants to
Yeah.
give it.
Would it be like from contrast?
All right, so because all of our images are in black, white, and scales of gray. So for diagnostic x-ray, all of your images will be in black, white, scales of gray. Think sonography may have some colors going on when they're in vascular trying to see blood flow, but for the most part, all of your x-ray images are in black, white, shades of gray. In our areas that we work in, they're typically going to be not very bright areas, so very low lighting. All right, so the example task that it gave you for that reason is so that you can look at the image quality, view images in dim lighting, read department protocols for imaging procedures, look at your examination requests, your monitors, and all of that. So typically everything's written in black and white, and then also your images are in black and white. All right, the next is hearing. All right, for technologists, and this is probably for medical people in general, you need to be able not only to effectively communicate, but when you're communicating with people, it needs to be within 15 feet and sometimes 30 feet, depending on where you are. All right, the reason for that is because you need to be able to hear your patients. You also need to be able to hear your the people that are engaging with you, whether it's your clinical preceptor, whether it's another tech, whether it's a doctor, whether it's a nurse. You have to be able to hear that. You have to be able to hear faint, muffled sounds sometimes, especially if we are in the OR and they have on those masks or any type of procedure when you have on a mask the voice sounds may be muffled, so you have to have pretty decent hearing. Telephone communication, you will have a lot of that within the hospital, between doctors' offices if you need to call and get clarification on that. So again, you need to be able to hear. Patient assessment, when you're talking with your patients, you need to be able to hear them clearly, so you have to have decent hearing. Responding to overhead announcements and beepers, all right, you have to be able to hear those. And then, of course, monitoring our equipment for malfunction, dysfunction, however you want to say it. A lot of the equipment is going to have like buzzers, beepers, to kind of warn you. Also, if you're in the hospital, I don't know if you've ever been in a place like Lowe's or Home Depot. Now, sometimes they're moving equipment around, like they're on these little, I don't know what they're called, ladders, but they're motorized and you hear the beeping behind you. All right, but there's a guide person there. Same thing in our field. You need to be able to hear the things around you. You have to be aware. All right, that's going to make sure that you're safe, and it's also going to make sure that your patients are safe. All right, the next one is gross and fine motor strength and coordination. So we'll talk about gross first. All right, this one allows for you to be able to move effectively, not only yourself, but our imaging equipment, your patients. One of the things that they like for us to be able to lift is at least patients at least 50 feet from the ground, a minimum of 25 pounds from the ground to waist level. Of course, a lot of our patients are way over that 25 pounds. All right, so your gross motor skills are going to help you with that. Also, standing and walking for long periods, standing up to 8 hours, sometimes 12 hours. Sometimes I feel like some people work, is it 312s? Maybe a little bit more than 12s, but so again, you could be standing on your feet for a long period of time. All right, this gross motor strength and coordination, that's going to allow you to safely transfer your patients, meaning maybe you need to help them transfer from a wheelchair to the table or from a stretcher to the table. So all of that requires strength. And of course, your patients will come in various sizes. You will also sometimes find yourself alone. All right, no one around. You're the only person, and you got to try to figure out the best way to get this patient's image. All right, so that's where the gross motor skills come in. All right, the next one is fine motor strength and coordination. All right, and this is going to allow you to manipulate your equipment. So if you look at some of these X-ray tubes that that we have, they have knobs and dowels, also buttons that you need to be able to manipulate, and that requires pretty decent wrist movement, finger movement, thumb movement, not only the manipulation of the equipment, but also the carrying of cassettes if your facility is a place that has cassettes. And I have had a student in the past that was not able to do this. Sometimes students are short stature and they're not able to I will say critically think, because even short people can figure out how to get that x-ray tube without help. But I've had students that had, things with their wrists and hands where they could not manipulate the knobs that we're required to use for collimation. And that became an issue in the clinical setting when they're trying to teach that student. So they have to have decent gross and fine motor strength and coordination. All right, I will come back to critical. Well, let's go ahead and hit critical thinking. Now, we don't expect students to go straight into the clinical site, just like they don't expect nurses or doctors to go straight into a clinical site and have it all down. There are, every day is a new experience. We learn things every day, but you do have to develop it over time. So allows for mastery of course content and also sound judgment in a simulated and clinical situation, adaptability to cope with constant environmental and patient changes. All right, every patient is not going to be that perfect book patient. Every patient is, for you all, not going to be that simulator patient or the lab patients that we have, which is your peers. Sometimes they're coming in there, they're mangled or they're unable to move and get into those positions that you need them in. So you still have to get the image, the best image possible for their diagnosis. So you have to then critically think, how am I going to get this image? All right. And you gain that along the way. You gain that by looking at what your techs are doing daily, and kind of putting all of that in your tool bag. All right, you must get the image regardless, so you have to figure it out. And in a lot of cases, you don't have a whole lot of time to figure that out, especially in a real busy place like an ortho place or even a super busy hospital. All right, the next one, interpersonal skills, and I feel like communication skills kind of go hand in hand, but interpersonal skills, that's going to allow you to um, communicate and work with others. So it's like your relational or relationship type skills. All right, you have to be able to work with your peers, your instructors, your patients, their family members, doctors, nurses, or anyone else on staff at the hospital, whether it's the staff environmental science, environmental services that comes in and cleans, whether it's the lab, you need, HCG results. It comes at all levels, and you have to be able to interact with various categories of people. All right, interaction with severely injured or critically ill patients, providing that patient education, working in a stressful environment, and also providing quality patient care. All right, that all falls under interpersonal skills. You will have patients that are coming in there. They might be inebriated, they might be unconscious, they might be angry, and you happen to be like the last straw. So they're not going to be talking to you nicely, but you have to be able to still, I'm not going to say you're going to let them abuse you. However, you have to keep your emotional faculties, in check so that you can care for that patient the best way you can. All right, communication, again, adequate communication, whether it's written or whether it's verbal. Sometimes we have to write, depending on how advanced our facilities are. Sometimes we have to write things in charts. Sometimes we have to type things in their electronic health record, which is for us, is going to be our radiology information system, where we type notes, whether it could be on the actual image, meaning we're I won't say it's dictating, it's what is the term? Annotating on the patient's image, or whether it's putting things in their chart to make whether the radiologist aware or other people aware of maybe things that was going on with the patient. Patient refused exam. Patient was unable, after multiple attempts, patient was still unable to do XYZ, and this is the best image that we could get. So again, you have to be able to communicate, whether it's face to face or whether it's, through the computer system. All right, emotional, adequate to maintain emotional stability and composure during stressful situations. Again, some of these patients are going to be in bad shape, or maybe they're just naturally rude. So you have to stay in control of your emotional response to that patient. So again, if you're in the medical field, you've probably already experienced this. If you're in customer service, you might have experienced this. So same thing. All right, you have to be able to adapt. All right, last thing is environmental. All right, adequate to tolerate the environmental stressors. All right, typically you're going to be working an 8 to 12-hour shift. Some places may even be a little bit more than 12 hours. Some places like they might have like sleep rooms and you're on a pager or you have a phone. But in any case, you have to be prepared for that 8 to 12-hour shift. Some techs don't even get to sit down all day. They might get that quick lunch break, and it might be eating lunch, on the go, like a brief second to grab a grape or something like that, just because their facility might be short-staffed, or they might be the only tech on staff. So again, that's going to require for you to have long periods of time on your feet. So you need to have comfortable shoes, of course. Some people have to invest in like compression socks based on that as well. All right, so you have to be able to adapt to that. When you go into the OR, when you go into the ER, that might be a very stressful environment, especially if they're bringing in a patient off the ambulance and they've called it in ahead of time so that you're aware. I forget what term they call it when they're bringing those patients in, but a patient that's in pretty bad shape that they're going to need X-ray there right away. Also, when you're in the OR, depending on the type of case and depending on the doctor, things fly in the OR. People get cursed out in the OR by the doctors, sometimes even the nurses. If you compromise their sterile field, you're definitely probably not going to have a good day in that case. So again, environmental things as well are stressors. So again, these are the essential skills that they pretty much say that all radiographers and learners coming into radiology should have. Now, if you don't have, well, some of these we don't expect you to have right away, like your critical thinking skills, even some of the interpersonal skills and communication skills. I've had students in the past, very quiet, very reserved. We kind of have to pull it out of them and they get to practice in the lab what is expected. And then they get to, of course, practice on patients when we send them out to the clinical site. So again, for you all, if you don't work, or if you work behind the computer and you're not good with those, we need to help you in some of your labs here online. Maybe you're working on a group project where you must interact, or you can try to find a job if you're not working that requires you to communicate with others and be involved and talk with others. Get you out of your comfort zone, basically. All right. If you have some conditions that um, won't allow you to meet some of these things, we do need to know right away, because when you get out to the clinical setting, they're not going to let you be involved in patient care if they consider you to be a hazard to the patient. And we can't send any students out that are going to be a hazard. So we rather know up front so we can see if there are things that we can put in place to assist. All right. And it's not necessarily discrimination. This is just a part of the job. All right. If you have a disability, like if you were blind, you could not be an X-ray tech. So again, some things that we need to know. All right. And those are the functional capabilities, whether they're physical or psychological. Also, going back to the emotional one, I have had students that were maybe taking some types of medication for mental disorders, whether it's ADHD or something other than that. It has to be managed, I'll say. You can have it, but it has to be managed. All right, 100% of the time. All right, the last thing we said that we would look at one more time, and we've looked at this before, is those ARRT competencies. All right, I just want to keep this fresh in your mind so that you know what you're up against when you do get to clinic. There's no time for you to waste when you get to clinic. Day one, you need to be, engaged and trying your best to get these. Now, they're not going to let you do them if they don't feel that you are ready. So again, practice with your simulator. Hopefully along the way, we'll give you some types of activities, have you build a collimator at home so that you can practice on some of your family members or friends, some of the positioning that you might need, and actually some of the collimation that you might need. All right, so again, one more time, when you get out into the field prior to graduation, in addition to those 120 hours, you must have all of these 10 mandatory general patient care procedures. All right, that is this top block that talks about the CPR. When you get that CPR, I would say don't waste any time getting it. I think it's good for 2 years. Once you get it, it needs to be AHA. All right, no other type of BLS certification. All right, and that's American Heart Association. All right, vital signs, blood pressure, temperature, pulse, respiration, and pulse ox. We'll try to ensure that you get that at clinic. Pretty simple check off there. Whether they allow you to do it on one of the techs, or whether they allow you to do it. Typically, we're not doing that on patients, so hopefully we will get them the tools that they need in order for you to be able to do it on a tech. Maybe you can work with one of the radiology nurses. Some of the departments have radiology nurses, especially our interventional departments, so that you can get those out of the way. All right, sterile and medical aseptic techniques. When you're doing some of your fluoro type procedures, you are setting that stuff up. So that's where we'll get that sterile and medical aseptic technique. Venipuncture must be successful, but if they have it, you can, even though it's not preferred, you can do it on one of those, I won't say it's a mannequin, but it's like a simulated arm. You can get it there, but the tech does have to sign off on it. Must be a registered tech, of course, or a nurse. A nurse can do these as well. Assisted patient transfer, whether it's from with a slider board, whether it's makeshift, maybe you're using a sheet to do it. Maybe it's even transfer from a wheelchair to the table, whatever that tech deems a successful patient transfer is what they can sign off on. And then the other one, care of patient with medical equipment. If you're transporting patients or if you're going to the ER, OR, up to the floor, and a patient has any type of medical equipment, make sure you are paying attention and taking notes so that you can let your tech know on that day that you would like to have that check off completed. All right, basically just says that you did an x-ray on a patient and that patient had all of these things going on with the medical equipment. All right, going back up to the top, 36 mandatory, 15 electives out of the 34 that are available. And out of the 34 that are available, one needs to come from our head section. We don't care which one, whichever one you see, because they are not very common. Most patients now for head, they are going to CT when they come in. But we do have some, like they might be getting cleared for an MRI and they need orbits. There will be opportunities for that, but that is definitely one that you can also simulate. All right, you can have some simulations. And then two must come from our fluoro studies. All right, so going back to the overall sheet, as you can see, those imaging procedures are broken down into chest and thorax, upper extremity, lower extremity, head, spine and pelvis, and abdomen. And then we have fluoromobile, peds, and geriatric. So kind of like what your simulator is broken down into, we have the different sections of the body that these fall into. All right. And then taking note on this form, Everything that has a mandatory check by it, you must have. All right, and then everything that has an elective, you only need 15, but 3 of them are taken per 2 categories. One from head, all right, we don't care which one you get. Skull, facial bones, mandible, TMJ, nasal bones, orbit, or sinuses. And then you must have 2 from our fluoro studies. All right, the easier ones are upper GI. That's an easy one. And then also small bowel is a pretty easy one. Small bowel is just a bunch of, after they drink, the barium is, and sometimes the small bowel series is on the heels of an upper GI, but you're taking a bunch of timed abdomens to see when that barium reaches the patient's ileocecal valve. Once it gets there, the radiologist comes in and does their imaging with the fluoro unit. All right, so those 2 are easy. Upper GI, small bowel series. The one that we don't like, or most techs don't like, is that barium enema, but you might see it out there. Esophagus, that one is pretty easy. The other ones are easy as well. It's just a matter of will you see them or not. And most of the time, even though there are images attached to it, like if we were in an actual lab that you would be required to do, when you get out to the site, it's usually a matter of getting the patient, educating the patient, getting the exam started, and then the radiologist comes in and does their thing. Sometimes there are after films that would be what you would be learning in a physical lab, but out in the real world, sometimes once the radiologist is done, the exam is over, you give the patient their aftercare instructions, which is usually for barium. Make sure you can resume your normal diet. Make sure you drink plenty of water because you don't want that patient to get constipated. We kind of alert them on what the color of their bowel movements may be, which is like a chalky white color, so that they're not alarmed, but they need to flush that out of their system. All right, so all of the mandatory, and then you can choose the 15 electives that you want, minus the fact that 1 needs to come from head and 2 needs to come from fluoro. All right. All the others you can choose. I would say get as many as you see, or the ones that you see, go ahead and get them. And then as you can see, we are only allowed 10 simulations at the bottom. And then ones that can be simulated, there's an eligible for simulation category. All right, so typically we would wait for simulations until the very last week or so in the program, but you all don't have a whole lot of time. But again, you can only have 10. All right, so any questions? I know we've seen this before, but I just want to keep it fresh in your mind so that you know what you need and the fact that you don't have a lot of time to play around once you get out to your clinical setting. All right, so now let's see. Let me look at the attendance one more time. We'll set up these breakout rooms. All right, so present now we have Amanda, Ashley, Carly, Cherish, Corey, Daniel, Dominique, Elizabeth, Erica, Ethan, Jasmine, Kennedy, Madison, Max, Mercedes, Michelle, Mindy, and Morgan. So that's 18 people. So let me create 9 breakout rooms. All right, the task again for your in-class assignment, I am going to place you in your breakout rooms. Right now, the in-class assignment is still at the bottom of your weekly modules, but I will eventually move it up to this week. All right, when you get into that breakout room, you will go back to that PowerPoint PDF that I gave you. We're going to the upper extremity PowerPoint. You're going to load up your simulator and you're going to follow. I put the page numbers slide numbers in the ICA, but you're gonna follow the instructions for the hand, and I need to see a PA, lateral, and oblique hand. All right, whichever one the simulator allows you to do for the lateral. We have two types of lateral. We have a fan lateral and we have just a regular straight lateral, whichever one the simulator is allowing you to do. All right, so let me create these breakout rooms. Any questions for me before we break out?
You said PA, lateral, and oblique, right?
Yes, ma'am.
We just log into our own simulation, right?
Yes, you're gonna log into your, even though you will be there with your partner, I do expect you all to kind of converse. All right, this is where we get that relationship building, that interactive, especially if you're not in customer service or if you're not in the hospital field where you're engaging with people. It's kind of to try to bring us out of our comfort zone. So when I do visit your rooms, I do, even though you're both, um, what you can do is one of you can walk the other through so that they're getting their images, and then so that you're not having to go back and forth to from the PDF to the simulator. One of you can walk the other one through. Once they're done with their images, the other one can walk them through by looking at the slides, okay? All right, so
And this would be RCA 6, right?
it will be, Jules. I feel like it's ICA 5. ICA 5. All right, because we didn't have one in the first week. See if I can move it. This is week 6. So let me move it. All right, I have moved it up to week 6, but it is ICA number 5. Rooms, we said we had 18 students. I'm going to, I'm gonna make 20 breakout rooms. However, I want you all to, actually, I'll assign them. Okay, go ahead, Erica. Oh no, crazy. I don't need 19 breakout rooms. I need 9 breakout rooms. All right. Look, looks like students fell off. Let me wait for them to come back in. How about this? I'm gonna let you all choose your rooms. But when you get in the room, there needs to only be 2 students per room. But I will let you choose your room this time. All right, once we finish this activity, meaning once you all have your images, we'll come back, we'll take a break, and then we'll talk a little bit about some struggles that you might have had. All right, are you able to move to a room? I wanted you all to choose your own room. I guess I chose it for you. Mercedes, if you could go to room 4, maybe. So I think we said 8:15. All right, so now we're gonna get in to this week's chapter. So we're talking a little bit about radiology administration. All right, and this is these are some of our objectives. Of course, we have 2 different slides. So provide an overview of the administration. This of a hospital radiology department and the structure of hospital organization. Describe how the radiology department fits into and complements the hospital environment. Understand the role of radiology administrators. Describe the functions of management, including planning, organizing, and facilitating, staffing, directing, controlling, coordinating, and project management. Discuss the transition from traditional functions of management to the requirements of managing radiology in our current healthcare environment. Describe regulating agencies. Excuse me. Describe regulating agencies that affect radiology and also discuss the characteristics of desirable applicants for employment in radiology. That's the last objective for this chapter. All right, so we're going to start off kind of discussing the hospital environment itself. All right, in the hospital environment, when you think about the hospital itself, if you've ever visited a hospital, it's like a little city inside of a city or inside of a bigger city. All right, so it's essentially like a little community with different people or different departments working together in order to help the larger community that it is located within or that surrounds it. All right, one of the main reasons why hospitals do exist is because there's a need, of course, for the hospital. All right, people come in because they're either injured, they're sick, they need some type of medical care, and this is where they get it from. Doesn't always have to be a hospital, but typically in a decent sized city, there will be a hospital. All right, so inside of that hospital, we have all different types of workers. We have doctors, nurses, rad techs, lab techs, we have pharmacy personnel, food services, environmental services, we have maintenance. So there's a lot of different jobs that are facilitated within the little community of that hospital. All right, and all of the different jobs are needed in order to keep things running. So all parties, no matter how important or unimportant we feel they are, all of them are needed in order to run that specific piece of the puzzle. All right, if one piece of the puzzle is missing, there may potentially be some type of lapse in the services that we're able to provide for our patients. All right, next is a hospital mission. Pretty much, I would say I'm not gonna say every organization, but pretty much most organizations, to include our hospitals, they are going to have a mission. So if you've ever researched a hospital's mission or the place where you work, their mission is basically focused on what their goal is or what their purpose is overall within that community. So the mission will tell you why the hospital basically exists, and it also is going to tell you basically what it plans to do in order to serve that community that it's located in. All right, so the mission is very important when it comes to the hospital. Even ANU has a mission. All right, every employee in that hospital, from the front desk to the operating room to radiology, even volunteers, they should not only know the mission, but they should be also working towards whatever their piece is in accomplishing that mission. So it's going to be important for them to know the mission, and we're all, no matter what our piece is of the puzzle, we're all going to be working together on our specific piece so that we can accomplish that mission. So just like a sports team, we have the different members on the sports team. So for soccer, we have the striker, the winger, the left backs, right backs, like the defenders. Everyone has their own piece of the puzzle, and while sometimes roles can I say collide or intermingle, we need every person on the team in order to meet or support the goals. So on sports team is to win, in the hospital is to ensure that we're providing quality patient care so those patients can get better. So with that being said, within the hospitals, there's different projects, there's different rules that are all put in place in order to accomplish whatever that overall mission is for that community. All right, any questions so far? All right, next is a little bit about organizational structure. So hospitals themselves, they're pretty much no different from any other business. They are businesses themselves. All right, and they have a chain of command. All right, and the chain of command is usually spelled out in what we call an org chart or an organization chart. Even ANU has an organizational chart, and I'm sure some of the places where you work have an organization chart too. All right, some can be very simple organization charts, or some can be pretty lengthy organization charts. So basically, in terms of the chain of command, at the top of your organizational chart for the hospital, there's some sort of board of directors or some sort of governing board that exists in order to kind of make not only the rules for the hospital, but also talk about some of the trends and the direction that the hospital needs to go. All right, the president is the next person on that org chart, and the president or the CEO, they answer directly to that board. All right, under the CEO, and we're gonna look at an org. I'll bring up an org chart in a minute, but it is in your book if you have your book available. Under the CEO falls all of the departments or divisions like radiology, surgery. There's a nursing division, pediatrics. Everybody has their own division, and then within that division, they have their own managers, and those managers report up. And of course, I will say they report down, but they do, they report up, and then they have others under them that are going to report up. All right, the medical staff, like the doctors and the nurses, they work in terms of leadership. They work within these little divisions in order to make those important leadership decisions for the team, things that are best for the patient. And they're also going to, that's more so the medical side, they're also going to advocate for their team on behalf of the patients as well. So the structure of everything is organized pretty much top down, even though some facilities, I won't say some facilities, some organizations are kind of changing this structure a little bit so it can be not necessarily top down where I'm directing everything, but we're working as a team collaboratively and listening to all viewpoints in order to get the job done. All right, hospitals, we need these organization charts. Businesses themselves also need these organization charts so that they can run smoothly. But for hospital's sake, we want to be able to run smoothly and safely. We want to know what's happening at the top. We want to know what's happening at the bottom so that we can work together to make changes that are that make things better for the patient. We can make things run more efficiently. All right, so a typical organization chart, an image from our book. Let's see. All right, this is the image from your book. Can y'all see my book? Okay. Didn't mean to do that. All right, so this is make this smaller. So this is an example of an organization chart or a picture of an example of an organization chart. So basically starting at the top, we have that board of directors. And as you can see laterally, they are concerned with quality control. So there's a quality council there. And then of course they have medical staff and an executive committee. All of these people make decisions. And of course, the CEO or the president, typically in a hospital, a lot of them are medical doctors as well. They report up, and of course, they report back to their teams that fall under them. All right, then as you can see, the chart is split into the different sections. So nursing services usually has someone that's over them. Support services usually has someone over them. All right, so in terms of support, as you can see, the volunteers are there. Pharmacy, I typically I would have thought pharmacy would fall over here under the more ancillary services, but over here it has it here. Nutrition services, these are all support for the hospital. All right, then under, well, this one is the way that this one is made. The COO has medical lab under it. Radiology falls under it. This is where I would feel that pharmacy would fall. And then, of course, security services. But these don't have to fall where they're falling. This is just an example of a chart. All right, then we have another little area. So this vice president is responsible for more of the admin services. So clinical management, materials, network services, so IT, physician support. Again, this is just an example of a chart. Then we have finance. Of course, without money, the hospital cannot run. All right, so we have financial services, they report to and who falls under them. And last but not least, we have an education department. This particular organization must have a school of nursing and a school of radiology. Those are popping up just in our area, in my area. Some of the hospitals have hospital-based programs, all right, and those all fall under education, all right. But again, this is just an example of an org chart. It doesn't have to look like this, and these people don't have to fall under these different ones, but this is just an example so you'll know what we mean by when we say an organizational chart. All right, moving on. All right, moving on to medical imaging. So, in my opinion, medical imaging is a big deal when it comes to the hospital. Without us, without our images, we would still be stuck. I won't say the stone ages, but we would still be doing like exploratory surgery to figure out what's wrong with these patients. So, with our images, doctors are able to take a look inside of the patient, determine what's wrong with the patient, and we assist with how the treatment plan goes. Not only X-ray, there's also some other important people like lab and also pharmacy. Without us, the nurses and the doctors would not be able to do their job effectively. So we do work hand in hand with other parts of the hospital, like the ER, surgery, labs. And that is all just to make sure that the patients are getting the care that they need in order to get better. So again, we are important overall for the patient. And we're also, as you can see right there, we are an important source of revenue for the hospital, important source of income. So essentially, without our images and the information that those images provide for the doctor, the patient's care would be definitely be delayed. And if you've ever had any medical imaging done, you will know if you had to pay for it that these images, these scans are some of them are very expensive. MRI probably being one of the most expensive of them all. And on top of getting the image, then there's typically like a radiologist fee or reading fee attached to it. So they can get really expensive really quick. And again, they are a source of revenue for the hospital. All right, so we are very important, even though I feel like a lot of, like when you get out of high school, you're in high school, some of, not now because TikTok and all these other social media platforms are here, but how I got into x-ray, even though I had broken something and had to have an x-ray as a kid, I never would have thought of x-ray as a profession. So I initially went to school for nursing. Um, since I was on a scholarship for ROTC, I was going to go in the military anyways, but I got tired of school and I live in a very small town where if you weren't a nurse or you didn't own your own business or let's see, you weren't IT, pretty much you might work in a factory, you might work in fast food. There weren't too many options. So I knew I was not going to go back home. So I ended up joining the Army, and based on where I tested, x-ray was one of the jobs that was offered to me. So, that is how I got into imaging, but it's not something that we really learned about, and still now don't really learn about some of these additional modalities outside of nursing, doctor, lawyer, the big things that are kind of pushed or out there for us to see. But we are pretty important, and without us, again, patient's care would definitely be delayed. Um, dang, was that hospital trends or did I skip one? Oh, no, this is the first one. All right, so now we're moving on to healthcare trends and hospitals. So some hospitals, so we look kind of at that organization chart, but some hospitals or medical facilities, they're kind of changing the way that they're set up. So instead of being super top down with that CEO being up there dictating everything, they're moving more to like a horizontal model where the departments are kind of working together more equally to help with the patients. You're also seeing these days, you have a lot more outpatient care versus inpatient care, and this is definitely preferred because it's a lot cheaper for the patient. All right. And so whenever possible, facilities are moving more to that outpatient model. It's cheaper for the patient, it's faster for the patient. They probably heal better at home anyway. So we're moving more to a horizontal organizational structure. All right. And the big push for this is more so to save on resources. All right. Those resources are very expensive. Of course, that cost is pushed down to the patient, and some of them don't have the resources or the money to pay for it. So this horizontal model is more of a way to, of course, reduce resources, reduce waste. With less waste and less resources being used, of course, that will reflect in lower costs for the patient as well. This last bullet statement right there, total quality improvement. We do want to follow that model or that strategy. We always want to try to find ways to do things better, to do things more efficiently, to do things cheaper if we can, while maintaining that quality for the patient. All right, so we're moving more towards this horizontal model. All right, and this is still with those healthcare trends. One of the issues with the hospitals now, or that a lot of hospitals are facing or up against, is they're getting less money back from the government. So Medicare, Medicaid, there's all of these little nuances and loopholes that are causing hospitals to lose money. All right, so we're getting less money back from programs like these. So of course, this is causing us to have to change the way that we operate and the way that we get paid. So a lot of these hospitals are scored, all right, and they're scored on the patient experience. So back in the day, it was more so about quantity, let's get them in, get them out. Now with these scores and the hospital score tied to reimbursement, they're moving more so to, or not moving because it should have always been about quality, but now we have to ensure that the patient is actually getting a good experience. All right, that's from the beginning to the end. They're typically not just going to see one department when they get there. So that first encounter to the last encounter, we all have to work together to make sure that patient has a good experience. So basically all departments have to ensure that not only we are operating in a safe manner, we have to make sure that we're respecting the patient, that overall that patient is satisfied when they leave. So bottom line, we're focused more on quality, which we always should have been focused on quality, but we're focused more on quality over quantity. All right. So if you've ever worked in healthcare or seen a bill, you know, they have all of these charges. We were trying to get away from all of the charges, you know, to get the revenue and focus more on that patient experience. So again, some of it's linked to how clean the facility is, how well you explain that procedure to the patient. Did they get better? And everyone, not just the nurse, not just the doctor, everyone within the hospital plays a part of that patient experience. All right. And that patient experience is definitely now tied to reimbursement. All right, so the next slide is the next two slides, we're looking at org charts again. So, and I'll pull these up. So a typical organizational design, and then the next slide, we're looking at a matrix structure. All right, so let me get out of here and pull up what the book shows. All right, are y'all able to see my book again? I didn't see any head nods. No? Okay, 1 second. All right, so we did look at an org chart up here. All right, but this is what we're kind of moving to. All right, so your vertical org chart versus a horizontal, more flat structure. All right, and these are the examples that it's giving you for your horizontal structure that we talked about. Right, and this is the matrix that it talked about right here. So this is, I won't say it's specific to radiology, it's still split. We have lab, radiology, nursing, personnel, and surgery, all reporting up to the president and CEO. And then, of course, the president and CEO reports to the board of directors. And then under each of these, you can see, you know, outpatient versus women's services versus outpatient surgery and peds. So this is basically the matrix structure. All right, and these are just charts that are in your book that I wanted you to take a look at. And we're not on this one. This one's specific to radiology, so we'll come back to that one. Oh, no. All right, moving on to radiology organization. So this is basically telling us how the radiology department is set up. Of course, it can look different depending on, what that department offers, the hospital size, the services offered. Not all hospitals are going to have every different service offered, but in this case, we are looking at all of the services. So most will have, we'll have the big umbrella of radiology, and then most are going to have smaller, more specialized areas. So as you can see right here, those sub departments, we're looking at diagnostic x-ray. So that's the general x-ray where they're coming in, we're taking those 2D images. They might have a CT department, MRI department, ultrasound, that's medical sonography, mammography, breast imaging. Says women's health, but men also can get mammograms if there's a concern, and they would go to mammography as well. Then we have nuke med and PET. Again, not all hospitals are gonna have that. You might have bone density or bone densitometry, and then of course, interventional services. So again, depending on what the hospital offers and what that radiology department offers, this is kind of what would fall under it, or this is what the structure would be like. All right, all of these are still some form of imaging, of course, all for their specific needs that the patient would need them for. So again, with having all of these different services, we have the big umbrella of radiology. All of these different areas would need some type of service support, whether that's scheduling, whether that's transport, whether that's equipment maintenance. Every one of these sub departments is going to need special support or support services. All right. The department itself, overall, is usually going to be ran or led by some sort of administrative director. Those administrative directors, typically, they're going to have some sort of strong background in business, but it still can be a radiologic technologist or an imaging specialist. So if you've worked your way up as a tech to become a manager, you can be the one that's overall in charge of the administrative piece of radiology. All right, any questions so far? All right, next, speaking specifically about your administrative director. All right, this is like our top manager for the department overall. That top manager of the department, they're going to be reporting to the upper administration, and they're also going to be working closely with a medical director. All right, your department will have, if we're talking about a hospital, they're also going to have a medical director, and that's usually, if we're talking about radiology or imaging services, usually going to be a radiologist. All right, your administrative director, their job is focused mostly on leadership and also management of personnel. All right, so their focus is really going to be staying on top of meeting goals, staying within the budget that they're given for the year, ensuring that everything's running smoothly. And some of these administrators, they look for them to have extra credentials like CRA, and that's a certified radiology administrator. That's something else that you could get from ARRT, your ARRT. All right, so a certified radiology administrator. So once you get that credential of RTR, again, you can stack on these additional credentials, and that's one of them. All right, and this credential is basically just like RTR tells the community that you are a technical expert in your field. This is telling those that want to seek to hire you that you're trained and you are knowledgeable about managing radiology departments. All right, the next person is a medical director. All right, typically the medical director, if we're talking about imaging, that's usually going to be a radiologist, and that radiologist is going to be in charge of making sure patient care and imaging within all of the departments, all of the sub-departments, he wants it to be quality or top notch. That's his job. And of course, he does work with the administrative director as well. Very closely with the administrative director, basically ensuring that everything is operating safely and that we're actually meeting all of the professional standards that we are required to meet. Your medical director is typically also going to chair or lead the department in terms of quality improvement efforts. So we should be constantly trying to improve. All right. So most departments have some type of quality improvement initiative that they're working toward, whether it's annually, quarterly. This is the person that's in charge of it. This is the person that you'll report back to ensure that we are on track to meet that goal. In terms of setting standards of care, the medical director is in charge of that. And again, he is a part of that hospital medical leadership team. And what he does is he reports up and of course reports back things that we should be abreast on. Well, he will report back to the administrator, and the administrator will tell us about things that we need to be abreast of, things that we need to be working towards, how we're currently doing, and how, of course, we can improve overall. All right, next is the radiologist. And the radiologist or your radiologist, of course, they're a medical doctor and they do specialize in reading those images for the patient. All right, the radiologists also, because we may have more than one radiologist on the team, they also perform some of the imaging exams, like your x-rays, or not the basic x-rays, more so the fluoro imaging. They're going to be involved in that. They might step into some type of MRI or CT because maybe we have some image guided things that we're doing. So they are very knowledgeable, and their job is to definitely read the patient exams. Your radiologist will have completed medical school, so they are a doctor. And then they have also completed a residency in radiology as well. So they're often going to be certified by the American Board of Radiology. When or if you become a radiologist, you can choose to work wherever you want. Some work in group practices, some are hired by a hospital, some are contracted out. Some are even now working remotely for some of these. A big one that I remember is the Nighthawk services. So they basically you send the images to them and they read them from home. Again, they must be a doctor, whether it's an MD or a DO. All right, and again, they're responsible for reading those images and providing that official diagnosis that the doctor needs for that patient. All right, the next part of the radiology department is our RSO. All right, and the RSO is basically in charge of making sure that we're using radiation safely. So there's a term or an acronym. The acronym is called ALARA, as low as reasonably achievable. So not only should we, the technologists, be working within that realm, the radiologist is working within that realm, and the RSO is testing wise and records wise, ensuring that we are working towards that goal as well, ensuring that not only the patient's radiation dose is low, but also the technologist's radiation dose is low as well. If the facility that you work at has radiopharmaceuticals or some type of radioactive material, meaning you have a nuke med department, or maybe your interventional department is working with radioactive material, maybe they're like inserting radioactive seeds or isotopes, the RSO is required by law. Again, they're responsible for setting up and also monitoring all of our safety type programs that we need within radiology, within all of the departments. All right, so again, they're there to protect the patients and also the staffs. Typically, your RSO is going to be a medical physicist, a board certified medical physicist or health physicist. But your radiologist can also, if one of those is not available, say you're a super small department, you don't have the funding or budget for a physicist, the radiologist can function as the RSO as well. So basically, their job is to ensure that we're preventing, monitoring, and ensuring that we're not overexposing the patients. As a technologist, when you do get out in the field, you're going to be given a dosimeter. Typically, even though the administrator or manager can monitor the dose, RSOs or medical physicists can also ensure that our records, our dosimetry reports are monitored as well, because as a tech or radiation worker, you have limits to what you can receive annually. Definitely more, we can get more than just the average civilian, but there is a limit, a safe limit that what we can have annually, and we cannot exceed it. All right, if we're monitoring our records as we should, once a tech reaches that limit, in my opinion, if I'm the manager, you're no longer you're you're no you've taken yourself out of the game, so to speak, because you can't exceed that limit, and now I can't use you. All right, I already have people there to do paperwork, so I don't need anyone else standing around to do paperwork. So if you exceed that limit, then you put yourself at jeopardy for, I would say, essentially losing your job. All right, because by law, we shouldn't knowingly have you continue to work knowing that you have met or exceeded the annual dose limit. All right, moving on. All right, now we're talking more about changing healthcare trends, how we're going how we're looking more at non-traditional healthcare. So as you probably know, if you've looked in your community or if you work in healthcare, that all of it doesn't happen just in this big hospital building. Now what you see UCCs, so those urgent care centers, urgent care facilities, those are popping up everywhere. You see outpatient services more, whether it's a surgery center, whether it's an imaging center. We see a lot of mobile imaging happening now as well. And if you are interested in mobile, those are the guys. They give them a vehicle, they give them a portable unit to load up in that vehicle. They have a phone and they have a laptop, and they go around to different places. A lot of them go to like your nursing homes where the patients are a little bit less mobile, or maybe they don't have the services to get them to the hospital. So they go to the patient to take the x-ray. You also will see more research labs. We have telemedicine. So we're not necessarily always going to the hospital now. We want to be more connected to the patients out in the community. And that means that we're outside of the hospital, because every place or every location does not necessarily have the funding for hospitals. Some little towns, those patients have to travel pretty far to get to their hospital. So now we're trying to change what your traditional healthcare looks like by making it more, I'll say more accessible to the patient. Even veterinary medicine or veterinary services in terms of imaging, they have imaging services. All right, because they image their animals that come in for care. In the military, we had to um, image the working dogs. All right, they were treated just like the service members. They are service members. So if they needed care, they would come to the hospital or to the clinics to get the service animals their x-rays. All right, we also have teleradiology services. So what we're seeing now, and someone mentioned the credential that's coming available soon in 2026. You see the MRI assistants. Some of these MRI techs are working from home. So there's someone at the actual facility setting the patient up, and then the technologist is running that scan from home. So again, we're stepping outside of that more traditional hospital setting. And again, that gives you also, as the tech, gives you more flexibility in where you would like to work. You don't have to work for a hospital. You can work for an outpatient center. You can work for a mobile services. You can work for, if you want to go into MRI and it's one that offers the ability to work from home, you can do that as well. So it gives you also a little bit more flexibility in where you can choose to work once you are registered in the field. All right, a few more minutes and we're going to put you on a break. A couple more slides, we'll put you on a break. All right, management function. So the next couple slides looks like we're talking about management function. So in my opinion, management is not just about telling people what to do anymore. These days, especially with all of the different generations that are out there, we have to get more into not just leading, but coaching and also supporting our teams. The millennials and whatever that group is after them, I don't know if it's Z, X, whatever they are in or are entering the workforce. So again, it's not all about, hey, do this. That group needs a lot more support, a lot more coaching, because they are very different from my generation and the generation that was, so my generation, what am I? I don't know what I am, but I can't think of what I am, but I'm not the baby boomer or the one after that, but pretty much my generation, you could tell us what to do. We might have some questions. We're going to get it done. There's not a lot of back and forth. We don't quit easily. We don't say, okay, well, I'm out of here. This new generation, I'm not saying we have to handle them with, kid gloves, but they are very different and they do need a lot of coaching. So with that being said, communication these days is really important, not only speaking and directing, but also listening. We have to listen as well. So as a manager, you have to be able to explain things clearly. And you also have to listen to your staff as well. If you don't listen these days, especially with the younger generation, they will quit on you very quickly, all right? Because they already know, especially if they have that credential with all these jobs out here, if they're not happy where they are, they're gonna leave. So I think one of the most important parts now of the management role is not only to listen, not only to coach and direct and lead, but also we have to listen. All right, we also have to ensure that we're that last bullet point right there, that continuous quality improvement. That's very important these days. So where it was in my time, we've always done it this way. We've always done it this way. A lot of us don't like change. Those above us or older than us definitely don't like change. This new generation they love change. They're very receptive to change. So as a whole, as a manager, we should be always looking to make things better, not only better, more efficient as well. All right. So, and this new generation is pretty good about figuring things out. You know, well, I won't say they were born with technology, but they're pretty tech savvy, whereas those my age, maybe definitely older than me, they're not as tech savvy, don't even like to use computers, but because we're digital, we were kind of forced to learn a little bit about it. Since we have EHR, we were forced to learn the computers. But this new generation that's coming in, they've always had computers. So as a manager, if that is the route that you're looking to take once you do get in the field, you have to be able to lead, coach, and also listen and support your employees and be open for change as well. All right, so managers do a lot. All right, there's a whole bunch of bullet points right here. So they're responsible for not only the running that department smoothly, they're responsible for planning projects, organizing the resources that we have or that we need, making sure that we have the right people in the right places. So they have a lot of jobs or a lot of hats that they have to wear. So not only do they have to guide the team, if we're having issues, they have to help resolve or solve those issues or problems that we're having. Of course, it can be a team effort, but overall, the manager is the one that's going to be left holding the bag if anything fails. We have to, as managers, keep things on track as scheduled or ahead of schedule, and then also coordinate between the different areas of the organizations that we might need assistance with or that we're working with towards that overall mission. So that last bullet point, project management, that's all of that stuff rolled up into one. That is the bigger part of your managers of these departments' jobs. So bottom line, they're making sure that everything gets done. Everything gets done in a timely manner, on schedule or ahead of schedule. And also they're responsible for meeting all the goals and objectives for that department. All right, so we will stop right here. It is 9:05. Let's come back at 9:20. 9:20.